Before we get started, I do want to acknowledge that this work was funded and completed in collaboration with Public Health Agency of Canada, and specifically with support of the Federal, Provincial, and Territorial Public Trust and Data Literacy Working Group. We were also very well supported by a number of other groups and people, including our own Public Advisory Council and Public Engagement Working Group and Leads team within HDR in Canada. All of the participants of our focus groups and interviews, which I'll talk about a little bit more in just a minute. And then more specifically, Brian Cho, Frank Gavin, Maureen Cully, Samantha Meyer, Kieran O'Doherty, Elise Mabey, Louise Binder, Nicole Armas, and Michael Harvey all provided insights, interviews, feedback, all sorts of different kind of contributions to the work. And then finally, Jonathan Dewar and the First Nations Information Governance Center helped to make sure that we're talking about Indigenous rights and Indigenous sovereignty in the most appropriate way, although anything that remains that's not right is obviously our responsibility, not theirs. Can we go on to the next slide, please? Oh, and I'm sorry, the last acknowledgement, of course, is CIHR, who is the funder, the major funder of HDR in Canada. So without CIHR's funding, we would not be able to do what we're doing here today. Okay, so the basic overview that we'll go through is a little bit of background and process for how we wrote the paper that we're announcing and making available today, the benefits and risks of health data collection, sharing, and use, and then we'll go on to public trust in the context of health data. What does that look like? And then we'll talk about recommendations for trustworthy practice. And then we will have some time for questions and answers. So I hope that you will be thinking about those and start putting those in as you're thinking about them as we go through the presentation. So next slide. So a little bit on background. There's, I think Julia and I have struggled because there's just so much to say about this whole topic, and there's a lot in the paper. So we're trying the best we can to give you enough information that hopefully you'll be enticed to read the full paper, but also to have the discussion with us at the end of this session. So there's a joint federal, provincial, territory action plan on health data and digital health, which was the foundation of the working group that was supporting this work. And of course, there's also a Pan-Canadian Health Data Charter. And these really were foundational background documents for us. Pan-Canadian Health Data Charter is also related to the working together plan that is part of the basis for the bilateral agreements between federal government and the provincial and territorial governments on funding, which has funding specific to health data embedded in it. The point here is that the foundational background documents that we started with, and the whole interest in us doing this work with the Public Health Agency of Canada, is very much grounded in other discussions and commitments that have been made across our various levels of government in Canada. And what we were asked to do was to create what we were calling a foundational paper intended to highlight public trust and key principles of health data sharing and use. So that was our remit. And then here's, here I want to just go a little bit more into the Health Data Charter, because it really is the piece that we connect all of the recommendations that you will see in one way or another to the 10 principles of the Health Data Charter. I'm going to go through this quickly. I'd encourage anybody to read this. It's a very, very short, simple document. It was developed by the expert advisory group for the Pan-Canadian Health Data Strategy as a starting point, and then modified a bit through the federal, provincial, territorial conversations. But there's just 10 principles. It was modeled after the idea of being very short and sweet and get to the nuts and bolts, like the Canada Health Act, which has 5 principles in it. And these were meant to be principles that would embed sort of the way that the things that we can all agree to before getting down into the details of how we might actually make these things happen. So we took the charter and made sure that all of the 10 principles of the charter are mapped in one way or another to the 6 recommendations that Julia will be highlighting later. And so this really is a grounding force for us. So just to give you a sense of what's in the Health Data Charter, it's the first and second principles relate to person-centered design and inclusion of the public in health data oversight in an ongoing and meaningful, deep way. Then the other principles relate to commitment to Indigenous data sovereignty and distinctions-based approaches to that, to protection of data and having common standards for data portability, for accessibility of data, for stewardship or governance of data, data use, data access, for timely and accessible data, ethical data use for a broad range of purposes. And that includes for social and technological innovation. And then also a commitment to harmonization of health data governance, oversight, and policy. And then the last principle relates to making sure that there's health data literacy for everyone. And this means everyone, not just the public, but it also means the institutions and the people in those institutions that are governing or collecting or using health data. The next slide, please. So if we're going to boil this down in some very simple way, the starting point that we took with this work is that data are from the people, meaning that the data we're talking about, health data, meaning healthcare service encounters or things that help us understand your health experiences. It might be your social environment, your physical environment, your socioeconomic status. All of those things are health-related data that help us understand healthcare services experience. And of course, then there's public health information as well. All of those data relate to people in one way or another. They come from people and they should be used for people. And so they have to be used in ways and for purposes that maximize benefits and minimize harms among the population in Canada, paying attention as well to the distribution of those benefits and harms as well. Okay, next. So the process we used in developing this paper was we spent a lot of time designing this and then implementing it. So we had the three components of the work that we were asked to do was developing a glossary of terminology, which was not meant to be the forever definitive kind of glossary because there's lots of work in health data glossaries going around. But the idea here was at least we could be consistent within our paper and then be transparent with the readers of the paper what we meant when we were using certain words. Then there was a development of benefits, risks, and protections for data, case studies, principles of public trust and data literacy. And then through this, we had lots of points for engagement with external groups. So we conducted focus groups. We had key interviews with people who had particular knowledge about areas such as trust, measuring trust, that sort of thing. And then a few opportunities for people to comment, for example, on the glossary. And then, of course, now here we are finally with the final report. Okay, so next. So I'm not going to spend too much time on this slide because of anything that is in this paper. I think that people who live and work and think about health data, we're pretty well versed in the benefits and risks. It's important to lay them out so that we're explicit about them. But I think these are the things that I think there's increasingly a wide, broad understanding of this. So some of the benefits that we can think about: higher quality care and fewer medical errors can come from the use of health data. We should ideally move away from expecting people and their families to carry binders of printed material around as a way to navigate the health system and ensure that the health system knows the things that it needs to know about you. We want to have a vibrant research and innovation systems because our ability to make people healthier, keep people healthier, help people help themselves stay healthy are all based on understanding use of health data and kind of keeping that innovation system going. We'd have high quality policy making from benefits, from the use of health data. And of course, we also want to think about timely response in the case of public emergencies. So that's not every single benefit that's out there, but that's some of the benefits that we can think of with health data use. At the same time, we know that there's risks with health data collection, sharing, and use. One of those is stigmatization and harm, and this is not a theoretical risk. This is something that people have experienced in the past. So that is something to be aware of, and it's why we think about equity dimensions of health data use in all of the things that we're talking about. There are security breaches, and I think everybody is aware of or many of you maybe have been affected personally from the loss of data, or a breach or disclosure of data. There can be a loss of privacy when those security breaches happen. And of course, this risk do vary by the group. So these are not risks that are necessarily equal distributed across the population, but different groups might have different risks and higher risks at different times. At the same time, we have to acknowledge the risk of not sharing data, not using health data. So this is not the greatest risk of all would be to lock data up and not ever let them be used. So this is why I go back to that the quote on the previous slide about making sure that we're actually using health data to improve health within the population and health equity as well. Okay, next slide. So here we then move into the areas of trust and trustworthiness. This ended up being quite an interesting part of the paper. I think Julia and I both spent a lot of time in the literature and really trying to wrap our heads around what the literature was telling us, in particular, some aspects of the relationship between trust and data literacy or health literacy. So here's some basic things we want to share about trust. So trust is embedded in relationships and shared values. So it's not an entity in and of itself. It's kind of an emergent thing from the basis of relationships. And it is distinct from reliance, for example, which is more transactional. So the idea here is that I might rely on a doctor to get, or another healthcare provider to give me a prescription for something. So that's a reliance. But I trust is more about the relationship, that I trust that somebody has my best interests at heart, that I trust that you have the knowledge that you need in order to provide me with good care. And so it is based on something that is deeper than just making a transactional, I'm going to pay you for something and you're going to give me something in return. Inherent in all of our interactions with health, public health, health systems, and so on, is that there's a power imbalance between the people who are receiving services or navigating systems of one form or another, and the governments and institutions that are providing those services, or creating policies, or creating systems of care, whether it's public health or healthcare services. And with that power imbalance, what we have to recognize is that the public has a choice about whether it trusts those institutions to be doing the things that are expected, but it does not always have a choice about whether they rely on those systems. So we have to rely, for example, on governments for certain things. That doesn't necessarily mean that there's automatic trust in government or other organizations or institutions. And that's a key difference, because trust is not something that you can demand or command, and it is not something that you're necessarily going to be able to keep indefinitely without ongoing work once you've earned it. So one very important piece of this is, if trust is relational, it also needs to be reciprocal. And what we mean by that is that governments, institutions, organizations want the public to trust them, but that means in a true relationship or reciprocal situation, governments and institutions and organizations also have to trust the public. So if there isn't that bi-directional, relational, reciprocal arrangement, then we're not really talking about a true relationship, and we're not perhaps thinking about trust in all the ways that we ought to be. And so if you kind of follow all of this through, what we really think about when we're thinking about what organizations need to do, and that includes government, is they need to come at this not saying we want you to trust us, but they need to come at this saying, what can we do to be trustworthy? So trustworthiness is the set of actions that are the basis on which trust is given, withheld, or withdrawn. Okay, next slide. So in the context of health data, I think I've said a fair bit of what's on this slide already, but essentially to give trust is to get trust. This kind of just underlines that reciprocal notion of things. And really, there's this ongoing question about, should I trust? From the position of the public, do I trust you now? And that evaluation of trust can happen in an ongoing way. And there's a few more things that I just want to put on the table here. It is very, very hard to define and measure trust. So we think about wanting to understand. I think lots of people have seen trends in trust, the declining trust in governments and institutions, particularly since the start of the pandemic. And those are likely real phenomena, but it is very difficult to measure trust, in part because it's not static, in part because trust in one part of a system does not necessarily generalize to trust in all parts of the system. So you may trust your own personal healthcare provider, but have less trust in the system as a whole, for example. As I've already said, trust can't be demanded or expected. Trust is not the same thing as compliance. It is that relational kind of thing, and it is complex, and it is earned through trustworthy behavior. Okay, so I think with that, I'm going to turn it over to Julia.
Thank you, Kim. Hi, everyone. I just want to reiterate Kim's thanks for everyone for joining us today. I did just get the dreaded Zoom notification that my internet was unstable. So if I'm cutting in and out, please someone put in the chat that that's happening, and I'll try turning off my camera. But hopefully everything is okay. So the paper is really centered around these 6 recommendations for trustworthy practice that we have here on the slide. And these recommendations are aligned with existing frameworks and principles, including those principles in the Health Data Charter that Kim presented. But we kind of present these in combination with this deeper understanding of trust in the context of health data collection, sharing, and use that Kim provided a great intro to. And as was mentioned, we're framing these recommendations around trustworthy practice to speak to exactly what was just said around moving the language from, well, how can the public trust us, to what institutions need to do to be trustworthy. So what we don't want to do is put the onus on the public to trust organizations blindly. So I will walk through each of these 6 recommendations. I'll share some principles and frameworks that are aligned with each of these, as well as some noteworthy Canadian and international practices that underlie each of these recommendations. Next slide, please. So the first recommendation is around organizing ongoing and inclusive public engagement. And Kim shared some of the language in the charter that really speak to this particular principle around person-centric health information design and the inclusion of diverse members of the public in health information system development and oversight. This idea of public or patient engagement aligns quite well with the idea of social license, which really means, public acceptability around uses and users of health data. So we do reference the IAP2 spectrum of public participation here. For those of you, I'm sure there are many here on the call who are familiar with that if you're kind of in the field of patient or public engagement, but essentially it's a spectrum that you could walk up from like lower to higher levels of patient or public engagement. But the take-home message here is that there's really no one level of engagement that is best. It does absolutely depend on your objectives. And another thing that we do highlight or acknowledge in the paper is that the main purpose of public engagement is not necessarily to increase trust. It's a democratic process that aims to bring diverse and underserved voices to the forefront, but of course, if done well, can strengthen the trustworthiness of organizations, and vice versa, if done poorly, can actually impede trust. Next slide, please. So a bit about some noteworthy practices related to public engagement. So when we look at the spectrum of public participation or public engagement models, we really need to consider feasibility, appropriateness. So there's many different types of ways to engage, from surveys all the way to more representative deliberative processes. We have an example up there on the slide of a routine trust survey. This one here is from the OECD. It's a commonly cited one. There are also representative deliberative processes. So we've included there on the slide the One London deliberations. This was, as an example, a 4-day, what they called Citizen Summit that brought together over 100 people living in London through debate, deliberation, to really understand their perspectives and expectations around how health data and social care data should be used, who should have access to it, and for what purposes. There's also a role for sequencing and diversifying engagement methods. So just as an example, our colleagues in Australia who work a lot around social license and understanding public perspectives, they conducted a national survey with a good few thousand people that explored public attitudes in Australia towards sharing health data with private companies for research and development. Then they actually followed that up by 2 citizens' juries, which are a more kind of in-depth deliberative process to identify gaps in public perspectives not necessarily identified in the survey. I do have there on the left side of the slide the Public Engagement on Health Data Toolkit from SFU. This is actually another initiative in the kind of the suite of initiatives that were being led by the FPT Public Trust and Data Literacy Working Group that Kim mentioned at the beginning. And so that is available on the SFU Morris J. Wask Center for Dialogue right now. And it goes into much more detail in terms of all these different methods that you can take to engage the public in the context of health data sharing and use. Next slide. So our second recommendation is around supporting Indigenous data sovereignty and reconciliation. So here we highlight key frameworks for Indigenous data sovereignty, which outline how public health and healthcare systems can uphold commitments to truth and reconciliation and nation-to-nation relations as outlined in the United Nations Declaration on the Rights of Indigenous People, or UNDRIP. In this section of the paper, we do talk about the importance of distinctions versus deficit-based approaches, as well as the importance of collective rights. So there are a number of frameworks which we highlight in the paper. For example, OCAP, which stands for Ownership, Control, Access, and Possession. These are principles from the First Nations. Then we have similarly OCAS, which stands for Ownership, Control, Access, and Stewardship. Those principles come from Métis nations. And the other one there that's on the slide are the CARE principles. So these principles were developed by the Global Indigenous Data Alliance. They were inspired by OCAP and were intended both to support Indigenous data sovereignty and to align with the FAIR principles, which I will mention a little bit later on. So these CARE principles focus on collective benefit, authority to control, responsibility, and ethics. And I just want to note that, of course, this paper acknowledges Indigenous data sovereignty and the importance of supporting reconciliation. We do not provide specific recommendations for building trust with Indigenous peoples in the context of health data, as we know that this would need to be an Indigenous-led and collaborative process. Next slide. So some noteworthy practices in terms of this particular recommendation. The First Nations Information Governance Center, they've developed a First Nations data governance strategy. That's that screenshot on the right side of the slide there. And really the goal of this strategy is to develop a First Nations-led national network of regional information governance centers across the country. In the paper, we also include an example about the development of a profile of Métis health status. And we included this because it does demonstrate a really meaningful collaboration between Indigenous and non-Indigenous organizations. In this case, the Manitoba Métis Federation and the Manitoba Centre for Health Policy. We've seen similar longstanding relationships, for example, in Ontario with ICES and the Chiefs of Ontario, where we see kind of clear and legally binding agreements, data sharing agreements, and data governance mechanisms that apply to data for over 200,000 First Nations peoples in Ontario. There's also the British Columbia's government's commitment to UNDRIP. They have specific legislation that frames that province's commitments to reconciliation. Next slide, please. So this is our third recommendation, and this recommendation is around creating clear rules for data sharing, access, and use. So this recommendation is part of a couple of principles of the charters, one about timely, available, and accessible health data, and another about health data governance, oversight, and policy. As an example, there is increasing international consensus around the 5 Safes framework as a guide for setting policies and providing transparency for data access, sharing, and use. So that's that little infographic we have on the slide there. We talk about safe data, safe projects, safe people, safe settings, and safe outputs, and I'll provide an example of that, I think, on the next slide. There are other frameworks as well, though. Sorry, I said next slide. That was tricking you. You can go back for a second. Thanks. Other frameworks, including FAIR, which I did mention. FAIR framework stands for findable, accessible, interoperable, and reusable. And there are other frameworks as well emerging from community groups such as EGAP. So that stands for Engagement, for Governance, Access, and Protection. And that was developed by the Black Health Equity Working Group in Ontario. CIHI is also currently leading the development of a data governance and stewardship framework and developing principles for stewardship as well. And now we can go to the next slide. So when we think about kind of noteworthy practices or how this would look in practice in terms of clear rules and supports for data sharing, access, and use, we do need to think about the differences in consent between primary and secondary data use. So when we think about consent in the primary data use, it often requires some form of consent. But if we're thinking about it in the secondary use context, for example, routinely collected data that's often kind of collected based on authority in relation to providing some sort of service. And it can, in that case, be used for purposes that are consistent with that collection. So individual consent in the secondary use case is not necessarily required. However, it's important to note that the individuals represented in these data still have interests in data use. And so the institutions do have obligations in relation to these interests. And that's why we are seeing kind of a growing movement or increased focus on community governance, like we see in the EGAP framework, for example. So I said I would talk a little bit about 5 Safes in practice. So just as an example, if we take the 5 Safes, if we talk about a safe project, that could be something like ensuring that there's scientific peer review. Talking about safe data, that could be, de-identification or anonymization of data. Safe people could mean having identified users who are part of an accountable organization or institution. Safe settings could mean trusted, secure environments. Often these are virtual virtual environments that can only be accessed by approved researchers or other knowledge users. And then safe outputs. So really the vetting of anything to move out of the secure setting. And as I said, this 5 Safes framework is quite commonly used in many institutions and governments internationally. Making data accessible also means documenting what is actually in the data, how they can be used, information about biases that may come from the data quality considerations. So all of these things really speak to the concept of metadata. What do we mean when we're talking about the data? So we've seen kind of the development of a number of different types of concept dictionaries and phenotype libraries that provide this type of data about the data. Next slide, please. So this is the 4th recommendation, I think, unless I've lost track of counting, but I think it's the 4th. And this is around public benefit or public good. And this directly aligns with the language in the charter that puts people and populations at the core of all decisions about disclosure, access, and use of health information. There are many challenges to defining and evaluating public benefit. I think we could have a whole webinar on that, so I won't go into it. But this concept of public benefit, I think, speaks to the importance of prioritizing both individual and collective viewpoints of health data use. So when we think about using or collecting or sharing health data, we can ask the question, what's in it for me? But we can also ask the question, what's in it for my community? What's in it for society as a whole? And sometimes these answers can differ, right? So this, I think, really forms the basis of public health in general. When we think about vaccination or introducing measures to reduce the spread of viruses, these things, the answers can be quite different depending on who we're talking about. This idea of public benefit as well is very much aligned with the Caldecott principles and the role of the National Data Guardian in the UK. So these principles were developed through a commissioned review that was really motivated by public concern about the use of health and social data in the national health system in the UK. So these principles are intended to guide both organizations and patients, and they apply to any sort of data that are collected for the provision of health and social care services where patients could be identified and instances where people would expect this information to be kept private. So there are actually Caldegot guardians who play senior roles in organizations or institutions that use and share health and social care information. I mentioned the EGAP principles a couple of times, but we're highlighting it here just to say that there's a very important role of community governance, as I said, and in defining and evaluating public benefit for specific communities. Next slide, please. So, as I just said, one way to ensure that uses of health data have public benefit is actually to involve members of the public in setting guidelines and guardrails. Community governance was identified in the BC Grandmother's Perspective report, and following this report, the release of this report, BC actually introduced the Anti-Racism Data Act, which became law in 2022, and this mandated the creation of an Anti-Racism Data Committee, which actually includes community members from across the province who have a variety of backgrounds and experiences. I'll also mention on the right side of the slide there, this was an initiative from the National Data Guardian in the UK, as well as Data Saves Lives, which I'll talk a little bit about later. They commissioned a public deliberation on how members of the public would actually define and assess public benefit. So I said that it's hard to evaluate and define, but there is work that has happened and is ongoing to really figure out what we mean by this. So some examples of their recommendations included the importance of trust and transparency. There was accepted commercial use with public benefit, and I think importantly, recognition that there can only be public benefit if data are actually used. So back to Kim's point around the risks of not sharing and using health data. Next slide, please. So this is the fifth recommendation, and this is around creating technology standards that will make data safe and sharing seamless. And this recommendation aligns with the charter principle that focuses on common standards for data use, including data portability, accessibility, and stewardship. So when we think about health data, specifically in the digital form, of course, information security and cybersecurity are important to consider. The example framework that we have here is the U.S. National Institute for Standards and Technology. This was recently updated. So it's similar to the 5 SAFEs in that it identifies areas that governments and other organizations should consider when developing their technology systems. And you'll see that governance is there in the center, and essentially here it just means that organizations having things in place for overall monitoring and management of information security. And in terms of data portability or protecting data when they're moved and used, I think nicely underscores that relationship between data custodianship, which is really about keeping data safe, and then data stewardship, which is more about ensuring that the data are actually used for public benefit. Next slide, please. So in terms of noteworthy practice, I don't think I need to talk much about this bill because I'm sure the majority of people on the call are familiar with it, but we've included here the Connected Care for Canadians Act, or Bill C-72, which aimed to facilitate data interoperability across the country, essentially by enabling the sharing of data across different platforms and preventing data blocking between different technology vendors. Unfortunately, as most of us probably know, the bill died on the order table because of the prorogation of Parliament and election, but hopefully will be reintroduced in some format. And there have been many other initiatives related to health data interoperability kind of leading up to this bill and ongoing, including the Health Data Interoperability Working Group's Interoperability Saves Lives report, which is a pretty highly cited report in this area. Next slide. And this is our last recommendation, and it's about creating transparent and ongoing methods of communication, including bidirectional and opportunities for learning and this idea of reciprocal learning. So of course, the key principle of transparency is brought in here, and this is where we bring in the data literacy piece as well. And I'll talk briefly about the data literacy piece because it's one component of our paper. It's not the focus, but it's an important one. We know that data literacy is one important component of public trust. And the general thought is that, if people have higher data literacy, this would translate into higher trust in health data use. This association is not as clear as you maybe would think it would be. For example, there's been some studies that show there's almost a U-shaped curve between data literacy and trust, so that both low and high levels of data literacy are associated with lower trust. In this case, the study I'm referring to was looking at trust in public hospitals. So it's a bit of a nuanced conversation to have, but our kind of stance and what we say in the paper is that data literacy should be viewed as one of several foundational elements of the possibility for trust, among other key factors. But there are other initiatives in this suite of initiatives, as I mentioned, as part of the FPT working group on public trust and data literacy that focus much more on the data literacy piece, including some training around data literacy that's being led by CHIMA. And if you recall, and we have it there on the slide, this recommendation is right in the center of our diagram. And we did that deliberately because we really think that it's a fundamental recommendation as it underpins all other dimensions of trustworthy practices that we've highlighted. So, if institutions don't communicate properly and clearly, for example, how they incorporate public good into their decisions around health data use, or they don't communicate properly and clearly the specific frameworks that they might use to ensure safe data sharing, then it's not really reasonable to expect public trust. Next slide, please. So in terms of some noteworthy practices around this recommendation, I mentioned Data Saves Lives, that initiative in the UK previously, but really this was the UK government strategy to ensure effective and safe use of health data. And it demonstrates effective strategies for communicating health data benefits, risks, and protections. So as an example, they've developed toolkits for the public and other health data partners to facilitate community dialogue around health data use and sharing. We also highlight, as a case study in the paper, actually, Greg's Wings. Again, I'm sure many of you are familiar with Greg's Wings, but really we included it as a case study in the risks of fragmented health data sharing. For those who are not familiar, Greg's Wings are an advocacy organization that was originally set up by the family of an individual named Greg Price, who experienced quite fragmented communication between his healthcare providers throughout multiple points of his healthcare journey, starting from when he was diagnosed with a serious but treatable health condition. But this fragmented communication ultimately led to his death, and he is the only Canadian at this point whose death has been attributed by an independent body to the poor management of his health information, although I would say his lived experience is certainly not unique. But since this happened in 2012, Greg's family has strongly advocated for significant healthcare system reform, and there have been many initiatives calling for improved health data interoperability. And then the other case study that we've included here that speaks to transparency and other things that can go wrong when things aren't done properly is we have there the Big Brother's Big Data Grab. And so this is about the General Practice Data for Planning and Research Initiative, GPDPR. And in the paper, we had to explicitly make sure that wasn't to be confused with GDPR. But this was an initiative introduced by the NHS in 2021, and it aimed to centralize patient data from general practice records to enhance healthcare planning and research. So of course, the purpose was public benefit to make use of the data, but it was not executed properly and was met with significant backlash from the public as well as other interest holders such as healthcare providers who cited, lack of transparency in how the data would be collected and used. Patients were not aware of the program or their ability to opt out. And ultimately, what was demonstrated was a significant decrease in public trust, which impeded public benefit. Because when people did find out about the program and they found out that they could opt out, millions of people did, because they weren't happy with how the initiative was executed. So I think this, we included this example because it really does underscore the importance of clear communication, robust data governance, and meaningful public involvement. Next slide. I think we're getting close to the end. We wanted to include these recommendations again, just to underscore the importance of trustworthy practices, because these recommendations really are the meat of the paper. What we really try to do with these recommendations is to offer a pathway to trustworthy practice for governments, organizations, institutions that collect, use, and share health data through these recommendations. And working quite closely with the Public Health Agency of Canada, we wanted to ensure as well that these recommendations had practical implications. So I do encourage everyone on this call to think about how these might fit within your organization or your work. And I think it brings us to the conclusion. So to conclude, our take-home message really is that a common framework for earning public trust and enhancing data literacy is essential for a consistent approach to policy development across Canada. In the paper, we also talk a little bit about who should be involved. Of course, FPT governments, that's a one that would, of course, come up. But we also want to see a movement towards true FPTI, so Indigenous working relationships, to further recognize nation-to-nation commitments that are embedded in UNDRIP. But in addition to government and governmental organizations, and those would include like CHI or CHI, if the aim really is true person-centered health data design, health data that are part of the design should come from, for example, ministries of health, but also EMRs, profit pay providers, nonprofit organizations, health charities, and last but definitely not least, the public, patients, family members, caregivers. So really, we're trying to reframe and expand the way we think about who is involved. And there's no one size fits all, especially when we think about the differences between primary and secondary data use. So I think, as Kim mentioned, there's so much to cover in this webinar, and even in the paper. There was so much more we could have covered in the paper, but we did the best we could. And yeah, so earning and keeping public trust does require, based on what we've learned throughout all these consultations, it does require many changes to current practice. For example, adopting new models of data stewardship, which I mentioned. This work is currently being led by CHI and the movement towards health data interoperability. And just bringing it back to the Health Data Charter, we hope that this set of principles from the Charter provides a common goal, and we hope that our recommendations for trustworthy practice can help earn public trust that will be essential for getting to this goal.